Thank you for having me and letting me share our experiences with reimbursement for this procedure. As my husband said, he started doing this in 2019 in the hospital. We didn't have our office-based surgery, and so he was doing this in the hospital. And he did a handful of cases, and the hospital stopped him and said, "No, you're billing." He was billing the anterior lamellar transplant code, and they said, "No, you can't bill that code. That's not what you're doing." And they went to AO and they said, "No, you can't bill the code." Well, I don't know how many of you remember Sue Visciarelli, who was the coding guru at the Academy for years. I was friends with her, and I went to her and I said, "This is what we want to do, that we think this is the right code." And they said, "No." Sue Visciarelli said, "No, you need to bill that with the unspecified code, the 66999 code." She went to the policy committee for us, and they said, "No, you can't bill it with the anterior lamellar keratoplasty code." We didn't want to bill it with the unspecified code. Who knows what you're going to get paid? Who knows when you're going to get paid? So what we did was that most of our cases were Blue Cross of Alabama. That's who was insured, these young keratoconics. And we told them what we wanted to do. John wrote them a letter and said, "We feel like this is a similar procedure to NTAX, but better." And they said, "Fine, bill the NTAX code." So Blue Cross of Alabama lets us bill the NTAX code for these. So we were able to resume doing these for our Blue Cross of Alabama patients. And that was really wonderful because they paid well for the NTAX code. We got paid better than the anterior lamellar keratoplasty code. But we had to follow the guidelines. Had to be over 18 and their cornea had to be a certain thickness. And so we were somewhat limited with doing those patients. Well, eventually the Academy came around with CTAC and said, yes, the anterior lamellar keratoplasty code is the correct code. So we were able to start doing those for the other payers. So our experience across payers is really everybody pays for this now if you bill it with the anterior lamellar keratoplasty code. It's not always automatic. Sometimes you have to do a prior auth or do an appeal, but we pretty much get paid by every carrier for this procedure. Sometimes you have to do a prior authorization. Cigna, Aetna, they like prior authorizations. And Cigna especially will deny it as a refractive procedure. They'll come back and deny it and say we don't cover refractive. They do that for PKs too. PKs, they say we don't cover refractive procedures. And when they do that, we just ask for a peer-to-peer review. We've been very, very successful lately, and they'll pretty much tell us right there on the phone, yeah, we see this isn't refractive, it's covered. So we've been able to, through peer-to-peer, and there are magic words, I don't know if y'all know this or your billers know, I mean your insurance department knows this, but if you say time is of the essence, they will almost always turn these around in 48 hours. It's a Medicare requirement, but it's pretty much, they do it for everybody. If you say time is of the essence on your authorization, they'll turn these right around and get these back to you. You don't have to wait weeks to get approval for these. Sometimes we have to appeal afterwards, even when we get an authorization. But the appeals are pretty quick and easy too if you do your documentation correctly. If your note really says what you're doing and why, pretty much you can get paid on any of these. We talked about the Blue Cross, we won't talk about that again. Again, why does it get denied? They may say it's experimental or refractive, or they deny the tissue. But that's not very often, and it's interesting because we almost always get invoice price for the tissue. That's when I've negotiated my contracts for the office-based surgery, I make sure that they put that code in and I get invoice price for the tissue. But some insurance companies like Aetna and Cigna and even United have a fee schedule for that V2785 code, and that's the same code you use for DMAC as for CAIRS tissue. And they'll pay us actually more than invoice price because they have a fee schedule. If it's DMAC, I'm arguing, no, you gotta pay me invoice price. But for CAIRS, sometimes they pay me what their fee schedule is, which is usually around $1,600. So you actually make a profit on the tissue for a lot of these without even fighting it. It's very interesting. AI has changed my life. ChatGPT has changed my life because you can take the patient's note. You can take his office note, you can redact the information if you want, this birth date, his name and date of birth, and you can upload that note into ChatGPT and say, write me an appeal letter or write me a prior authorization letter for this patient, and this is what it needs to say. And it will write you a beautiful letter, and it will pull that insurance company's policy. You say, this person has Aetna, I need a prior authorization to do CAIRS on this patient. This is his note. And it will go through and pull all the relevant data. Your billers will love this if you share this with them, because it takes, appeals used to be on my to-do list. I'm gonna write an appeal for this one. I hate to do it. Take me an hour to write an appeal letter. It's 5 minutes now. You know, it's just quick and easy for a prior auth or an appeal letter, and it has it knows the relevant information to put in this appeal letter. So it really is much easier to do this than it ever has been. Again, sometimes you have to tell ChatGPT, you know, say that the patient is going to have a PK if they don't have this, or say this is the only alternative, or they've failed glasses or contacts. So you can just say, add this to the letter, and it knows where to put it, and it's beautiful. It will write the whole thing for you, and you will get paid. But we do this in the hospital for our Medicaid patients because Medicaid doesn't allow office space, but we do it in the office for everybody else. And there isn't one insurer that I say, no, y'all can't do that case. You know, they will pay these. Taking a picture. Again, documentation is important. You've got to make sure your note is saying the relevant information so your billers can get these paid. Visual impairment, conservative, say they've tried glasses and contacts, or, you know, there are these, the people doing the reviews don't have any idea what they're looking at. They just have a checklist. You know, they want to know, yes, the patient failed conservative treatment. Yes, this is the only thing you can do other than a PK. So you want to make sure you put this stuff in your note to get paid. But the bottom line is CAIRS gets paid. We really do not have any trouble. It is much easier than cross-linking was at the beginning. It's much easier than DMEC for me. These are really not a problem to get paid for. This is kind of an actual appeal letter. So I just plugged in somebody's note just a couple of days ago just to see, and I don't know if you can read this, but I just said, I need an appeal letter for this patient who we did CAIRS on. And they wrote this, ChatGPT wrote this letter, just pulling from his office visit. So as long as you're documenting correctly, your billers can get paid for this. It's very easy without a lot of work. It's changed my life.
I've had a little different experience with Cigna here. I tried all this. I used ChatGPT. I sent, with Cigna, it was an automatic. The pre-authorization was sent back as a denial. Either they said we need more information, or just like you said, we don't cover refractive procedures. And I did create a letter just like you described, and I've had no luck. I've tried it maybe 4 to 6 patients already.
Really?
Yeah. So would I be able to, can I get your template or maybe a sample letter? Maybe I'm missing something? Or,
Sure. And have you asked to do the peer-to-peers?
I haven't done the peer-to-peer yet. I just sent
Usually those are automatic for us now. Those have gotten much easier. Used to, they would put somebody on the phone with you and they would say, yeah, I see this isn't refractive, I see, but we can't overturn this. Now, pretty much 5 minutes they've overturned it.
All right. Are there talking points that I can use with the peer-to-peer
That's pretty much what these are kind of my talking points, you know, saying that they have progressive keratoconus or ectasia, they have functional visual impairment, conservative measures have failed, this is not refractive, and we really have not, the peer-to-peers to me are the key with Cigna. That, right.
An internist who no longer sees patients, they know nothing of ophthalmology, and they know very little of that payer's particular guidelines.
Right.
And so we have to be the more informed on the call. I make sure that I talk to that peer-to-peer reviewer very respectfully, and I basically say, what's your name? Okay, I got that. Now your name's in the medical record. We want to make sure that you're not making medical decisions on behalf of this patient. I am. And it sort of becomes a conversation of, this is not refractive, this is preventative, this patient's going to go on to need a PKP.
Right.
You're either paying a few $1,000s for this, or you're paying, if we do it in a hospital center, $23,000 for a PKP.
Right.
And so in every single instance, they back down very, very quickly. But it is an effort, and it's a worthwhile effort, to get to the point of the peer-to-peer. It's not uncommon for my personal assistant to be on the phone on hold for 4 hours before we get to the point where we can get a peer-to-peer authorized and scheduled. So it's a worthwhile endeavor, but the more we all do that collectively with all the payers and all the different regions that we represent here in this room, the easier it's going to become.
Yeah, and I think it is becoming easier and easier. We have been, again, if you say time is of the essence, a lot of times you can get the peer-to-peer within 48 hours. They'll do it right away for you. Sometimes I tell them, okay, what's your name? I'm gonna tell the patient you're the reason they're losing their vision, and they don't like me to say that. So a lot of times, if that's my last resort, but they will come around usually. We've been very successful. Like I said, there's nobody that I just won't do.
One of the issues,
How big is my billing department? Until a year ago, it was me. I have one other person now. So, yeah, in-house billing. So, many years ago, I had another career, but my husband wanted to go in the room and take care of the patient. He didn't want to worry about any of this stuff, and so I said, I got you. So, I've been there from the ground up, and I did all the billing. I did all the negotiation. With our office-based surgery, I got contracts with Cigna and United and Blue Cross, and I've got good contracts with all of the payers, and you just keep asking until you find the right person to talk to, and you can get it done. I just really believe in what we do, and I think it's valuable for the patient and for the practice. So, and for the insurance company, it saves them money to do it in our office as opposed to doing it in the hospital, where we were operating. That's the only other place we operate right now is a hospital. So, that's pretty much.
question please?
Yes.
Here in Florida, we seem to have an issue with the payers where we do the surgery. If you don't have an office-based surgery facility like you have, here in Florida, many of the payers will not pay the surgeon fee nor the tissue if you do it in your office. Have to do it in a surgery center or in the hospital, excuse me, in order to get paid, reimbursed for those two portions.
Well, I had to negotiate. I had to battle the insurance companies to get that, but I was able to, and they're coming around. So even United, on their website now, when you go to do credentialing, they've got facility credentialing, they've got office space.
You have an official office-based surgery
Official
facility.
office space, yeah.
Most of us do not. Those of us who do not have
Well,
a valid office-based surgical facility in Florida are at risk for not getting paid surgeon fee or tissue fee doing it in the office.
If you don't have an office space, if that's what you're saying. So what you do is you just become you just make an official office-based surgery. So there's nothing, you just get an MPI and a tax ID, and that's your office, but you just bill through that. Then you get both. We are actually Quad A certified, but we weren't until the first several years we did office-based surgery. We didn't have any certification. We just were not. We were just office-based surgery. We just had the surgery, and we got a tax ID.
My experience, having done several of these, sharing my experience, having done several of the intacs, we stopped doing them because we were not getting reimbursed. And when I started doing CTAC, we had an uphill battle initially, and found that the payers would only reimburse surgeon fee and tissue fee if we did it in the surgery center. That's 2 years ago. I can't tell you that that has or has not changed.
I think they are changing, and I'm telling you, when you go,
And Florida's unique.
Florida is unique. I agree with that. I understand that. My daughter lives down here. She's a B&L rep, so I do know that it is different. But I do know that what you have to do is call up your credentialing people and you ask them. And if you get a different tax ID and NPI, you can build that facility as the office, you know, and they'll pay. We just get paid two different checks. We get a facility fee under one tax ID and NPI, and the surgeon fee under the other one for United and Aetna and Cigna and those insurers. But it's getting easier and easier. When you look at the credentialing on Blue Cross now, at least Blue Cross of Alabama, but I know on United Healthcare nationally, they have office-based suite. Office surgical suite is one of their credentialing checks that you can check to ask to be office. Surgical suite is what they call it. So you really don't have to have any credentialing for that. You would just be billing it as two different claims. That's really about all I have, if anybody has any more questions. But you can get paid. I mean, Medicaid pays, everybody pays for this. It's really not a challenge with the anterior lamellar keratoplasty code, which everybody's on board with now, I think.